Good afternoon, everyone, and welcome again to the webinar Warm Vertical Compaction Technique, the Trail of the Fill. My name is Jackie van Herk, and I'm your technical host for today. And our speaker is Dr. Julian Weber. If you have any questions, you can ask them in the Q&A on the bottom of your screen. We will answer all your questions at the end of the webinar. For now, I would like to wish you all a nice webinar and good luck to Julian.
Thank you, everybody. I hope you can hear me, possibly see me. Thank you for the opportunity to talk to you on three-dimensional obturation of the root canal system. Thank you, Dentsply Sirona, for your confidence in me in providing this webinar. To be honest with you, I don't usually talk about obturation, so I did spend a considerable amount of time putting this lecture together, and I really do hope you enjoy it. I call this the thrill of the fill, but I'm not the first person to say the thrill of the fill, but there's certainly no doubt that a well-root filled canal, especially a well-root filled canal with accessory anatomy found, and the culmination of many steps, is certainly an exciting part of the endodontic procedure. However, it does need to be stated that regardless of what techniques we are using, we do need an evidence base to support what we are doing. And I hope to include this as part of my lecture. So I think it's fair to say that in over 50, 60 years of endodontics, there certainly is universal agreement regarding the endodontic triad for success. We need to shape our canals. We need to clean our root canal systems in 3 dimensions. And then finally, we need to fill those root canal systems 3-dimensionally also. We can't really talk about filling root canal systems unless we talk about cleaning in 3 dimensions, and we can talk about shaping canals. So when we fulfill the ultimate objective of our triad, we are, of course, looking to eliminate the question of apical periodontitis or apical periodontitis of endodontic origin, which is the disease process that makes us go to work in the morning and carry out our endodontic procedure. Our aim is to eliminate bacteria, but also at the same time eliminate the anatomy in the root canal system, which could provide a substrate for any bacteria that we may, in fact, leave behind. Eliminate bacteria, eliminate the anatomy. Provide the best biological environment for healing, and that would also include the need to place a good restoration on the tooth once we have completed our endodontic procedure. So we are shaping, we are cleaning, and we are filling, and we are finishing with a good coronal seal, bearing in mind that a well root-filled tooth requires a good restoration in order to ensure a successful long-term outcome. So our final objective is to fill the root canal system 3-dimensionally. And you can see here a collage of radiographs from my dear friend and colleague, Cliff Ruddle, who has fulfilled the final objective, and in the words of Herbert Schilder, has eliminated the root canal system as a potential source of disease. This is what we are looking to achieve we are looking to achieve this with our final obturation. And there's no reason really why we can't, as clinicians, obtain these sorts of results. So filling root canal systems represents the culmination and successful fulfillment of the procedural steps that comprise start to finish the endodontic procedure. Why obturate root canals? Well, we could say that this is our last chance to treat the disease of apical periodontitis, because we can hermetically fill the root canal to render the remaining bacteria harmless by entombing or burying them and utilize the antimicrobial effect of filling material and sealer. So this is the last chance. If you look at the bacterium Enterococcus faecalis, which is present in all our retreatment situations, we know that the gutta-percha and the sealer, in this case, in this article, AH26, or Grossman's sealer, were effective in killing Enterococcus faecalis indentional tubules. Some endodontic sealers are not. And the study indicated that obturation with gutta-percha and sealers that are capable of eliminating residual bacteria in the root canal system may improve treatment results in both approaches. So it's an undeniable fact that we have to fill our root canal systems, and we have to fill them truly three-dimensionally if we can. Now, when it comes to the restorative impact in terms of success, we need to, as I've already stated, stress the importance of the final restoration, because the restoration of an endodontically treated tooth is considered a major determinant of its survival. And when we see failures, most of our failures are not actually treatment failures, but they are in fact restorative failures. This was a landmark study carried out by Salarabi and Rothstein from the University of Southern California, looking at a whole cohort of insurance-based root treatments, nearly 1,500,000 root treatments. They did have a huge survival rate at 8 years, 96%. But where they had failures and where they had extractions, 85% of those extractions were due to a lack of full coronal coverage. So if we fail to restore, we can expect ultimately to fail. So we can see here, we can offer all manner of reasons as to the continuation of endodontic infection. We haven't found the canals. We haven't cleaned the canals properly, and we haven't filled them properly. And when we do this properly and place the final restoration, we can expect a predictable outcome. Now, I'm not going to spend any time today talking about restoration of the root-filled tooth. That is a question for another rainy day. But we will, of course, be looking at the question of filling root canal systems truly three-dimensionally. But you know, there's no point in me talking about filling root canal systems three-dimensionally if we haven't found all the canals. If there's 93% of first upper molars have 4 canals, well, then we have to find those 4 canals. If 60.4% of upper second molars have 4 canals, we have to find all those 4 canals. There's no point in talking about the endodontic triad of shaping, cleaning, and filling three-dimensionally if we haven't located every canal within the root canal system. Whenever we see failure of root-treated teeth, we certainly in these upper molars, we see a very high incidence of second mesial buccal canals that were not found. Untreated canal space is a major cause of failure. This upper molar's got 2 mesiobuccal canals. It's got 2 distobuccal canals. It also has a palatal. It has 5 root canals. This is a root canal system of 5 root canals. And these 5 root canals must be found, shaped, cleaned, and filled in order to disinfect the entire root canal system, in order to fill the entire root canal system. If we miss 2 canals, we are 40% less than where we should be had we found all five canals. So files do the shaping. The files shape our canals. And we do need to talk a little bit about the relevance of shape in terms of the filling procedure, because these instruments that we have at our disposal, whether they be hand instruments, whether they be mechanical instruments, will need to produce a continuously tapering preparation from coronal to apical. And into that preparation, into that tapered preparation, we are then able to use copious amounts of sodium hypochlorite to dissolve soft tissue, a 2 to 5% solution. We can heat up the hypochlorite to coffee heat bleach to destroy bacteria and improve the tissue dissolving ability. And at the end of the shaping procedure, we can use a final irrigant of 17% EDTA solution to remove smear layer. Why are we removing smear layer? Smear layer, just to remind you, smear layer is that product of organic and inorganic debris that is pushed onto the wall of the canal, into the dentinal tubules, into the accessory canals by the rotary mechanical instrumentation. This pushes debris where we don't want it, and the EDTA will remove this debris and open up these tubules, open up these accessory canals so that they can be cleaned and ultimately filled. We irrigate because 35% of our canal walls are totally untouched by the instruments that we have at our disposal. Still today, many colleagues think we are using the instruments to clean canals. We're not. We're using the instruments merely as a means of producing the shape in the main canal so that we can place irrigant into the main canal. And complete irrigation is not complete until complete irrigation is not completed until we have fully shaped our canal. So we have to fully shape the canal with mechanical instruments, rotary reciprocating instruments, and at that time we can then be satisfied that our irrigant has moved to the full length of the root canal, and we can then spend time using and moving irrigant into the root canal system to provide three-dimensional disinfection. There are many products available that we can also use to enhance irrigant effectiveness, and we can activate with many products. I'm a great believer in the Endo Activator, which was developed by Cliff Ruddle, and this is a sonically vibrating, sonically vibrating plastic tip, which we insert into the fully shaped canal at the end of the shaping procedure to provide us with that really clean canal. We have a fully shaped canal full of the hypochlorite, 30 to 60 seconds in each canal with the correctly sized activator tip. And we then replace that irrigant with EDTA, and we will then do exactly the same thing. So we have to also consider where we're going to terminate our preparations and where we are going to terminate our root canal filling. So working length, where does it all end? Where is the best end point for preparation, and where is the best end point for obturation? Well, for many of us, we would possibly say the apical constriction. But the apical constriction is now recognized as something that is not proven as being present in more than 50% of the canals evaluated. So yes, we may consider this area here at the cement dentine junction as the narrowest portion, but is it truly the end of the canal? Or should we be looking to terminate our preparations here at the foramen position? So when we are short of the radiographic, apex, our instruments are actually, let me just go back, our instruments are actually closer to the apical foramen than we think. So in the past, we traditionally would have been told to take our instrument 1 millimeter from the radiographic apex, and this position would be the ideal location for our preparation. But as you can see here, the apical foramen is actually not at the end of the canal. Indeed, we could be through the end of the canal when using this sort of concept. A radiographic working length ending 0 to 2 millimeters short of the radiographic apex provides more often than expected a basis for unintentional over-instrumentation, and as such, unintentional overfilling of the root canal system. At the same time, the instrument we use to measure the length of the canal is always longer than it appears radiographically. So you can see here that the instrument actually appears to be at the radiographic apex, but indeed, it's truly through the foramen at the end of the canal. Now, if we don't get this position right, not only will we overshape the canal and over-prepare the canal, but we will overfill it at the same time. And I think it's clearly understood the problems of overfilling and the impact that that has on healing. So when the instrument is short of the radiographic apex, it's actually beyond the apical foramen in more than 43% of the cases. Even if the apical constriction is 0.5 millimeters before the apex, then 66% of all our measurements are beyond the apical foramen. So we have an instrument at the radiographic apex. But in truth, the end of the canal is at the apical foramen, which you can see is at this point. If we then prepare to the radiographic apex in this case and fit our gutta-percha cone, you would assess that the image on the left is a better image of placement of the gutta-percha cone, whereas the image on the right shows it's been placed in a poor position. However, this is the reality, as you can see. So instead of guessing the best location, instead of historically saying the apical constriction, we should actually be looking for what I would call the electronic apex. And I can measure the position of the electronic apex with an apex locator that gives me a 0 position. And this is where I'm going to prepare to, and this is ultimately what I'm going to fill to. The electronic apex is the 0 position on my apex locator. So I'm not relying on radiographs, and I'm not necessarily relying on guesswork. I'm using my apex locator. And I'm working to the 0 position. It's a fallback position that I can constantly refer to throughout the shaping procedure and the filling procedure. Now, at the end of the shaping of the canal, I can truly measure the length of that canal with a paper point. And this is important to me because I'm also going to use this paper point measurement technique to fit my gutta-percha cones. So I'm going to use a series of paper points to dry the canal. And the last paper point that I use slips through the foramen at the end of the canal. And I can measure to this point here, and I would call this the bleeding point. This is the point where the inside of the canal meets the outside tissues. Surely that would be the most relevant position to finish my preparation, and for the purposes of obturation, the most relevant position for obturating. I'm going to fit my gutta-percha point to approximately 1/2 millimeter from the bleeding point measurement, as you can see here. And then with a tapered gutta-percha point in a tapered canal that fits well at the end of the canal, I know there's less likelihood of any overfilling. So we need to understand the relevance of shape. And again, Herbert Schilder clearly defined this for us. We must shape our canals so that we can clean them, and we need to shape our canals so that we can fill them properly. He said, unshaped canals cannot be cleaned and unshaped canals cannot be filled. So this is why I've spent this amount of time talking about the concept of shape, because it's all intertwined. Shaping leads to good cleaning leads to good obturation. So the requirements for successful obturation. Well, the filling should be capable, the obturation should be capable of densely filling the root canal system. It should be able to provide a fluid-tight seal from orifice to apex, and it should prevent any reinfection. It's a fluid-tight seal that we're looking for. And we can be pretty certain that poor obturation quality is always associated with non-healing. In this classic article from 2002, they showed that poor obturation quality was associated with non-healing in 65% of cases. Shugal, Clive, and Spanberg looked at the radiographic appearance of a completed case, and they confirmed that obturation at the apical should follow to the apical terminus without any access into the periapical tissues. We should demonstrate filling in 3 dimensions, and the filling itself should appear as a dense radiopaque mass and fill the root canal system. We can assess criteria for judging the success of root canal fillings. How would we assess and judge from the radiograph? Well, we need to ensure that we at least go to the minor constriction from the canal orifice to the minor constriction. We should be fully aware of the concept of shape and the shaping technique that we use. And we need a dense filling with no voids visible at all. I think it would be fair on the basis of this article and what we really know that any obturation which is 0 to 1 millimeter short of the apex is better than an obturation which is 1 to 3 millimeters short of the apex. And both of these situations would be superior to obturations beyond the apex. So we need to be mindful of these factors when we fill our root canal system. These cases were shaped with the Wave 1 Gold technique and then warm vertical compaction of Gutta-percha, which we will look at in more detail in the next part of this lecture. We've fulfilled our objectives of the endodontic triad for success: shape, clean, and ultimately fill. And when we fill, we're trying to fill as much of the root canal system as possible. So when it comes to obturation of the root canal system, we do have materials available to us, few different materials. But even today, as far as I'm concerned, the requirements for the ideal properties of root canal obturation materials were clearly defined by Lou Grossman, one of the grandfathers of endodontics in the early 80s. The root canal filling should be easily introduced into the root canal. It should be radio-opaque. It should seal the canal laterally as well as apically. It should not stain tooth structure. It should not shrink after being inserted. It should not irritate periapical tissues. It should be impervious to moisture. It should be sterile or easily and quickly sterilized immediately before insertion. It should be bacteriostatic, or at least not to encourage bacterial growth. And this is an important final property of a root canal obturating material and technique. It should be easily removed from the root canal if necessary. So there is no point in using a root canal system, a root canal filling technique that we cannot easily remove. So if we look at what's available out there in the marketplace, and I saw from the survey carried out that most of you are undertaking one of these techniques, we have lateral compaction or condensation. We have vertical compaction and the continuous wave of condensation technique. These are roughly considered together as one by today's standards. We have carrier-based techniques of Gutta-percha on plastic core. We have carrier-based techniques with a Gutta-percha core, with Gutta-percha on the core. And we have single cone techniques with bio-ceramic sealer. Now, I'm not really going to talk very much about this. I will allude to it in a second or two, the single cone technique with a bio-ceramic sealer. But you know, I was a big lateral condensation man for the first 20 years of my career. I think many of us understand lateral condensation. A single Gutta-percha cone with sealer is placed into the canal to length. A root canal spreader is placed alongside it. This creates space for additional Gutta-percha cones until we build up a mass of Gutta-percha throughout the whole body of the canal. Now, actually, this is a very time-consuming technique. And to be honest with you, although I use this technique reasonably successfully, I was still looking for an alternative, believing that warm vertical compaction and the ability of warm vertical compaction to seal lateral canals was more ideal. And I dropped this technique in about 96, 97, after I had spent time with Steve Buchanan and Cliff Ruddle in California. Now, Ben Johnson developed the thermofill technique. This is three-dimensional obturation of warm Gutta-percha, alpha phase gutta-percha is coated onto this plastic carrier. It's a low viscosity gutta-percha and it flows very nicely. There's more than 25 years of follow-up with this technique and some 200 published articles. It's technique sensitive, however, and because of the flow of the gutta-percha, many colleagues were concerned about overfilling. You will know the system, I'm sure. We have a thermoprep oven, and we have matching thermofill obturators depending upon the shaping technique that we use. More recently, the thermofill technique has been superseded by the Gutta-core technique. A Gutta-core technique, again, is an alpha phase gutta-percha, cross-linked polymer chemistry that makes the carrier and the core almost, the carrier or core and the coated gutta-percha almost as one, and this can be truly driven into the root canal. Now, as you can see from Sergio Cutler's video here, this does truly three-dimensionally fill the root canal and accessory anatomy. Slow insertion of gutta-core, terrific movement of the gutta-percha into the cleaned root canal system. Filling the root canal system three-dimensionally. So this is a very good technique. For some reason, it hasn't really taken off in Europe. It's quite popular in the United States. I'm not going to talk about this technique today because I want to talk to you about the true warm vertical compaction technique. But Giuseppe Cantatori, who's probably one of the greatest advocates of the Gutta-core technique, these are some of his beautiful cases, as you can see here. A true three-dimensional obturation of the root canal system, filling the root canal system three-dimensionally. Now, just before I look at the question of warm vertical compaction, we do have this question of bioceramic sealers, of which there are now many products out there, and single cone techniques. There are some interesting articles suggesting that a single cone technique with a bioceramic sealer is a viable option for obturation. I do feel that the jury is out on single cone obturation with the bioceramic sealers, a gutta-percha cone with a bioceramic sealer. And I have had colleagues who have told me that they've gone back into these teeth at a later date and the sealer has not even set. So does this product fulfill the requirements as set out by Grossman for the ideal property of a root canal filling material? I'm not sure that it really does. Well, let's come back to this maybe in a few years' time, but for me, I want to fill my root canal systems three-dimensionally. And what I want to do is to continuously and progressively carry a wave of warm gutta-percha along the length of a master cone of gutta-percha, starting coronally and ending apically with apical corkage. So this gutta-percha cone that I'm going to fit as my main cone for the warm vertical compaction technique should match the last file that was used in the shaping of the canal, and at the same time we have matching paper points to easily dry the canal. So gutta-percha cone fit is really the first place to start. But you know, there's gutta-percha and there's gutta-percha. So traditional gutta-percha master cones are either hand rolled or machine rolled. Yep, there are places that machine rolled the gutta-percha points. And the problem with this is that none of these points really match the shape of the canal. If we intimately want the gutta-percha cone to fit the shaped canal, if we really want heat to move that gutta-percha apically and laterally, we need a well-fitting cone. And there is now a new generation of gutta-percha cones called Comfort Fit from Dentsply Sirona. They have a micronized formula where all the components are very densely packed together, which provides excellent heat flow up to 4 millimeters or even more. And these gutta-percha points are matched to the files that are used to shape the canal. They're injection molded in electrical discharge machines with tolerances of plus or minus 0.02 to give a predictable and perfect cone fit, improve formulation, and more importantly for the warm gutta-percha technique, for the vertical compaction technique, a heat wave extending a great distance from the heat source. This is a true system-based approach. So these Dentsply Sirona confirmed fit gutta-percha points, you can see here from the thermal profile, the plugger has severed the heated and severed the gutta-percha coronally, and the heat is moving 4-5 millimeters beyond the heat source, providing us with an opportunity to compact and move a wave of condensation down the canal as part of the warm vertical compaction technique. The warm vertical compaction technique, filling root canal systems as truly three-dimensionally as we can, is obviously not a new technique, but it has been technique sensitive in the past. We have now streamlined it so that it is possible for all colleagues to use this technique. The use of warm gutta-percha and movement of warm gutta-percha has been extensively studied in the literature. And gutta-percha still, at this moment in time, is the best material to hydraulically plug apically and laterally. The gutta-percha cones and the techniques that we use are used in conjunction with a recognized root canal sealer. For Dentsply Sirona, that would be AH+ resin-based sealer, easily introduced into the canal. Further sealers would be Kerr's pulp canal sealer, which was originally developed as a zinc oxide eugenol-based formulation for the warm vertical compaction technique of Dr. Schilder. Now, the root canal sealer itself should consist of a semi-solid material. The root canal filling consists of a semi-solid material in combination with the root canal sealer to fill the voids between the gutta-percha and the root canal wall. So that is the main function of the sealer. And it should be biocompatible and antimicrobial. It should be absorbable into the tissues, and any breakdown should affect and improve the healing. AH Plus has been well documented and used now for many years, and has excellent positive research. AH Plus showed the most optimal tubular penetration and adaptation to the root canal walls of the sealers inserted. Now we can use a jet mixing syringe, which is automatic mixing with disposable tips, and we get considerable placement of the gutta-percha, of the sealer, into the canal. And you can see we can hydraulically move that sealer when we place the gutta-percha cone. So let's look in more detail now at warm vertical compaction. And let's look at the original technique of Dr. Schilder to see how we took this technique and translated it into something that is a lot easier for all of us. So we have a tapered preparation with a tapered gutta-percha cone coated with sealer. The apical tip of the cutback cone is larger than the foramen, so we're not going to push it through. We're going to heat up the gutta-percha and remove little bites of gutta-percha, and then we will use a corresponding size plugger to compact and move it gutta-percha apically and laterally. So removing these little bites of gutta-percha 3 or 4 times until we're left with an apical plug of gutta-percha. This was the basis of the original technique from Schilder. And what is left can now be filled with injected gutta-percha, unless you want post space. There's excellent apical control of this with this technique. But it is time consuming and technique sensitive. Stephen Buchanan simplified the technique with the System B technique, calling it the Continuous Wave of Condensation. System B, downpack plugger, and traditionally the Obtura 3 Max for back filling the canal. Now, the problem with these devices is that they are full of cords, wires everywhere. And I don't know about you, but I hate wires, cords all over my surgery. When it comes to obturation, we now have many cordless obturation devices available to us. And I want to talk to you about the Gutta-Smart product from Dentsply Sirona, a cordless obturation system. So the Gutta-Smart obturation system works with the conform fit gutta-percha points, a warm vertical solution that flows together, a downpack device, and a back filling device with no cords. The downpack device, which we'll look at in more detail in a minute, has a cuff activator here. When we activate this cuff, heat is generated at the tip, and we will use this to drive that gutta-percha point down into the canal apically and laterally. Now, we can also place onto the downpack device a thermal response tip. The thermal response tip will heat up to 90 degrees. We can also use this to assess the vitality of a tooth and its response to heat. Similarly, the flow device has a cuff switch and a flow heater into which we will insert individual cannules of gutta-percha. We have these stainless steel electric heat pluggers. The activation cuff can be pressed 360 degrees anywhere around it. An audible tone sounds when the tip is activated, and the tip is heated up to somewhere between 160 to 200 degrees, depending upon which type of gutta-percha you're going to use. As far as the electric heat pluggers are concerned, we've got a small plugger, 40 tip with a 0.025 taper, a medium electric heat plugger, 50 and 5%, and a larger electric heat plugger, 60 and 6%. You would mainly find that you're using this medium or this smaller plugger in most canals. So we would select one of the electric heat pluggers, push the electric heat plugger onto the end of the pack handpiece until it seats firmly, and we can swivel it around into any one of 4 positions. We can do the same with the thermal response tip. We would set the heat setting at 90 degrees for this. If we're using the conform fit gutta-percha, we need to have the heat setting around about 160 degrees. This reading here represents the tone volume as the heated plugger moves down the canal. With regards to the flow handpiece, we have the removable heating element into which we can use the single-use cartridges of gutta-percha, a 360-degree activation cuff, heat status indicator. We would select a gutta-percha cartridge, either 20, 23 gauge or 25. The 23 or 25 gauge would be preferable, especially in the narrower canals, because we want to be able to insert these gutta-percha cartridges down to the full depth of the apical plug of gutta-percha. We will thread the flow heater onto the device with the gutta-percha cartridge in place, tighten it, and bend the cannula to the desired angle using the cannula bending tool. Again, it's a lower temperature gutta-percha as developed for the conform fit system. The gutta-percha from the flow device is manufactured with the same technology. So we are going to pre-fit our plugger into the canal. We're going to select an electric heat plugger that will loosely fit through the straight portion of the canal and optimally to within 5 millimeters from the full working length. We can then fit our gutta-percha cones. These are fit to length and roughly cut back apically based on the paper point technique that I showed you earlier. We dry the canal with the paper points. We're going to coat the gutta-percha point with the sealer and take this into the canal. We need a series of pluggers to plug incrementally each section of the canal. Let's look at how we use the downpack device. So we're going to activate the Gutta-Smart downpack handpiece, searing off the non-useful portion of the master cone. And you can see we have considerable heat transfer. We then use a large pre-fit plugger, which will generate a wave of condensation and automatically compact the warm gutta-percha vertically and laterally into the root canal system. We're then going to take the electric heat plugger and we're going to push it through the mass of gutta-percha, carrying a wave of continuous condensation deeper and deeper into the canal, moving gutta-percha into accessory and lateral canal anatomy. As we approach the pre-hit measuring length, we're going to deactivate the tip, giving it an opportunity to cool down. We're then going to heat it once again, and this will provide a separation burst of heat and allow us to remove the excess gutta-percha coronally. We can then plug this apical mass with the pre-fit pluggers. We're now ready to backfill. Again, when it comes to backfilling, if we're using the conform fit gutta-percha, a lower temperature should suffice. 160, 170 is more than adequate. So we are going to bury the flow device cannula into the gutta-percha mass and count to 10, and this will heat everything up to the same temperature, which will avoid any voids in this area. This will thermally soften the coronal-most aspect of the apical plug of gutta-percha. Press the activation cuff on the gutta smart and dispense a small 2 to 3 segment of warm gutta-percha into this region of the canal. We will use a larger plugger to fulfill a reverse wave of condensation and then incrementally backfill with the flow device, the Gutta Smart flow device, until we filled the body of the canal. So we pre-fit the gutta-percha here into the palatal canal, burnt off the excess with the Gutta Smart electric heat plugger. Now we're going to drive the downpack plugger through the gutta-percha towards the apical 1/3. Count to 10, separation burst of heat. Plug the apical mass. Place some sealer and then inject the gutta-percha. This is very, very simple, giving us a true 3-dimensional fill. And here you can see the distal buccal in action. It's a pretty rapid technique. This is almost real time on this video. Remove coronal excess, plug with a suitable size plugger, drive the electric heat plugger into the gutta-percha, an apical mass plugged, now this is an interesting case because you can see we have 2 orifices below the main orifice. 2 canals come off 1 canal. The only way we can fill this is with the warm vertical compaction technique. Because we can't place 2 gutta-percha points together into those 2 canals, when the entrance of those two canals are below the main orifice. So we insert the gutta-percha cone into one canal and remove the excess at the entrance to that canal. And we now have the space to place the second gutta-percha point. We can then burn off the excess, plug apically in both, and then inject the gutta-percha into the body of the canal. So this is the only real way that we can fill these two canals. If any of you could provide me with a technique to fill these two canals, other than this warm vertical compaction technique, please send me an email. So let's just look at some literature before we finish off the webinar. How are we going to assess the quality of our obturation? Well, we have leakage studies. We have studies that look at the replication of root canal anatomy. We have studies that look at the ability to fill lateral canals. We have studies that look at sealer solubility and thickness, radiographic quality and density, and I suppose most importantly, outcome studies. Now, when it comes to leakage studies, there's probably over 1,000 articles in the literature on leakage. There are many different ways to assess leakage, as you can see here: dyes, isotopes, bacterial penetration, etc., etc. The problem with leakage studies is that there is no real consensus as to a standardized statistical methodology. And there's no doubt about it that leakage, if we are going to use it, we need more evaluation of the reliability of all of these methods before we say that one particular filling technique seals the canal system better than another. How about replication studies? Replicating the entire root canal system. Well, in this interesting article, they compared three gutta-percha obturation techniques to replicate canal irregularities. Within the limitations of the investigations, the evidence suggests both warm techniques, that's warm vertical compaction and continuous wave, were significantly better at replicating defects than the cold lateral condensation techniques. What about the ability to fill lateral canals? This is the classic Goldberg article from 2001. They compared lateral condensation of 5 thermoplastic gutta-percha techniques to obturate simulated root canals in extracted teeth. System B with the Obtura backfill demonstrated a greater number of lateral canals obturated than lateral condensation. And what about sealer solubility? At each level, lateral condensation resulted in significantly greater sealer loss than vertical compaction. Only significant in the lateral compaction group. I don't think things are looking very good for those of you who are using lateral compaction and hoping that you'll get good long-term results. What about the comparison of the density of cold lateral compaction versus warm vertical compaction? The results showed a statistical significant difference in density with greater fill of gutta-percha by weight for continuous wave versus lateral condensation. But the quintessential way to determine whether a result is good or not would be an outcome study. And the outcome study would be the University of Toronto study carried out in the early 2000s by Shimon Friedman and his team at the University of Toronto. And they looked at basically Schilder's warm vertical compaction technique. Schilder's tapered preparation technique with warm vertical compaction versus a standardized step back technique and lateral condensation. So they had good success rates determined as healed, healing, and functional at 95% in a two-part prospective study over 4 to 6 years. But in addition, the flared preparation with the vertical compaction had a statistically superior success rate than the step-back technique with lateral condensation. So if we are to treat periodontitis of endodontic origin, I do think we need to consider a warm vertical compaction technique. Cone fit, obturation, the perfect fill. So in conclusion, let's remember that obturation completes the triad of shaping, cleaning, and obturation. Three-dimensional obturation is a logical scientific conclusion. And simplifying 3D obturation is the goal of modern technology. Gutta-percha still today remains the benchmark for three-dimensional obturation. So the thrill of the fill, I still get the excitement waiting for my final radiograph. I can't wait to see the final result, especially when I've used a warm vertical compaction technique. So participants, thank you very much. Of course, I'm now open to questions. Jackie?
One moment. Thank you very much for your presentation, Julian. In the meantime, I would also like to thank our participants. If they can fill in the questionnaire that I'm pasting in the chat right now, then in the meantime, we can also answer the questions. I see one for now. What is squirting technique for root canal obturation?
Well, basically the squirting technique would be the flow device, and the gutta-percha is squirted into the canal. The gutta-percha is injected into the canal and then compacted with pluggers incrementally throughout the length of the canal. The only real problem I see with this technique is I feel it's a little bit difficult to be certain that you actually have got the gutta-percha to the full length of the canal and truly filled the root canal system three-dimensionally. But it's a one-shot, a one-shot technique of the flow device of the Gutta-Smart product.
Okay. Maybe in the meantime, people are still, well, they're still able to ask their questions. So maybe we should wait like 1 or 2 minutes before we actually close the webinar. In the meantime, I would really like to thank you for your presentation and the fact that you that you created this for this webinar. We really appreciate it. And I see another question. I get sometimes I get frustration when filling deep splitting. I can clean them, shape, but filling is not so reliable.
Well, I mean, I don't know what technique you are using to fill those split systems, but you remember the last video that I showed whereby you're going to fit the gutta-percha cones separately and burn off the excess at the entrance of each canal. And then you can visually see the entrance to the second canal, and then you can insert the gutta-percha cone in there also. So that is a very technique sensitive situation, and only a warm vertical compaction technique would be suitable.
Okay. Another question in the chat. I see. Why do you do portions of Gutta-percha during downpack instead of one flow?
The Stephen Buchanan technique is the continuous wave technique. That's driving the gutta-percha, driving the electric heat plugger through the gutta-percha mass into the apical 1/3. Some purists would say that that technique may not pick up as much accessory anatomy as doing it in portions. So that would be my reasoning behind that, to do it in portions to ensure the greatest opportunity for movement of gutta-percha laterally into accessory canals and dentinal tubules.
Okay, well, I hope that answers his question. For now, I don't see any more questions, but let's just wait for a couple more seconds because people are still attending. You can either ask your questions in the Q&A or in the chat. Both options are good. And in the meantime, we would really appreciate it if you can fill in the questionnaire we created for this webinar so we can keep improving our webinars. I pasted the link in the chat.
Is that time to stop the share, do you think?
Yeah, you can stop sharing. I will answer this question because if the webinar can be watched again later in people their own time in their own area. Yes, I will send everyone a thank you email who attended the webinar with the link in it of the recording. And if people were not able to attend, they will also get an email with the recording link in it. So yes, we will send you the link so you can rewatch the webinar. I think this was the last question for now. And I would really like to thank you again for doing this webinar and wish everybody and you a very nice weekend.
Have a great weekend, everybody. Thank you again for the opportunity.
Bye-bye.